Thank you so much for joining us, Dr. Mandel.
Thank you, Anne Marie. I'm happy to be here.
Well, I would love to start off by hearing how you, an anesthesiologist, ended up starting the Ketamine Center, getting into ketamine treatments. What led you into this world?
My ketamine center is called Ketamine Clinics Los Angeles. I founded it 6 years ago. Many years before that, I went to graduate school in clinical psychology. I was a PhD candidate. I completed all of my requirements short of my dissertation, had my pilot project accepted, and was working on my dissertation when I had the opportunity to go to medical school. And I took that opportunity. It seemed really exciting. Actually, I had thoughts of psychiatry when I started medical school. I ended up really loving the certainty and the power of giving micrograms of stuff into kilograms of person and seeing a very predictable effect within seconds, no kidding. So I finished at USC Medical School. I went to, I did LA County General. Internship was really a busy internship at the time. I did an internal medicine internship. They were separate from residencies then. I went to Mass General for my anesthesia and finished at UCLA and started out in the community as an anesthesiologist. Loved it, did it well. Had a pretty flourishing anesthesia practice as a mobile anesthesiologist. As surgery migrated from the OR to outpatient surgical centers, I migrated with it. And I had my little rig with a SUV and a crash cart and a defibrillator and oxygen, and I went around town, dental offices, podiatrist offices, interventional radiology clinics, plastic surgeons. Loved it. But I continued my interest in mood disorders. I'm an intellectually curious person, but real truth is, I had depression and suicidality in my own family, and it really kept me tuned in, and it made me hyper aware of breakthroughs. And when I heard, and I didn't hear it until a few years after it happened, that these guys coming back from Iran and Afghanistan and having surgeries here stateside to repair war wounds had ketamine as an anesthetic. And I don't think I've mentioned ketamine yet. They had ketamine as an anesthetic. And on rounds, it was remarked upon, gee whiz, Joe's not having so many bad dreams. Joe laughed at a joke. Joe went into a room the other day. He went into the day room, and he didn't have to sit with his back to the wall and his eyes on the door. What's going on here? And it took almost a decade for people to put this together. It's a great paper by Berman in 2000 about the observation of the impact of ketamine on treatment-resistant depression and PTSD. I don't know if you want citations and stuff like that. Stop me if I'm getting too weedy. Anyway, this was very exciting, but totally not believable. Ketamine was the most widely used anesthetic in the world. It was approved in 1970 by the FDA for use in humans for anesthesia. And it's an amazing drug. It very quickly became the darling of the battlefield medical community because ketamine in sub-anesthetic doses, what we call analgesic doses, given IM, could very rapidly make a wounded soldier numb enough so that he could actually participate in his own evacuation, despite his wounds. This was mind-blowing. An anesthetic that supported respiration and cardiac output, holy smoke, who thought of that? But it worked. I mean, there are a lot of guys alive today because of that. Anyhow, all the entheogens were interdicted by Richard Nixon and his war on drugs in 73. And nothing survived. They were all class 1 drugs. Even cannabis was a class 1 drug. Ketamine survived because ketamine was the most widely used anesthetic in the world. So we got literally hundreds of millions of experiences giving ketamine. Anyway, back to the 90s. The the findings were really not believable, but they kept being reproduced. In 2006, a guy named Zarate at the National Institute of Health put together the first double-blind, placebo-controlled, randomized, blah, 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 the whole gold standard. And what do you know? 71% of his previously treatment-resistant patients, these are patients who had, you know what treatment resistance is? Adequate trials of 2 or more of the traditional antidepressants pushed to a level where it either was definitely proven to work or got too toxic to continue without benefit. So 71% of these people who were really at the end of the rope had relief of their depression within hours to days. This is totally mind-blowing. This is a spectacular result, and this really caught my attention. I didn't really learn of Zarate's study for a couple of years, but around 2008, it was brought to my attention, and I became fascinated. I was chief of anesthesia at a plastic surgery center, and the guy was a really nice guy, and I said, can I try this in the recovery room after hours? And he wanted me to watch his patients so he could go elsewhere. And some physician has to be in the suite as long as there are patients in the suite. So it was a suite trade. And I tried it trepidatiously for free on acquaintances, and it was mind-blowing. It really was transformative, and quickly, and with no side effects. And I was off to the races. This was just the most amazing experience for the patient and for the provider. It's so wonderful to do something that's transformative for another person. So here I am. I started my clinic, and increasingly I wasn't able to do anesthesia and ketamine infusions. I had a background in psychology, so I was way ahead of a non-psychology trained anesthesiologist, but I didn't know as much as I wanted to know, so I learned more. And I also learned that I don't have to know everything and be able to do everything. I just have to know where I end and involve colleagues who can fill those gaps. Because ketamine is not a cure at all. It's a treatment. It's an amazing treatment, but it's a treatment. It doesn't fix everybody, and it doesn't fix anybody, or very, very few, permanently. So in the interval provided by the relief from depression, which is much longer than reported in the literature, but is not infinite. Literature says, depending on who you read, about a month. You know, in my clinic, we average 3 months. We say we have an 83% success rate. That's an amazing success rate. Well, what do we mean by that? We mean by better than a 50% reduction in symptoms for at least 3 months. And in those 3 months, you've got to pile on all the other adjuvants to wellness. You've got to pile on sleep hygiene and nutrition and exercise and an intimate interpersonal relationship with a peer. It doesn't have to be a carnal relationship, but an intimate one where both care about the other. And talking therapy. And if you'll do those things, I'm including mindfulness as part of this, you'll have a transformed life, not for a week or a month or 3 months, but for the rest of your life. And can you coast? Can you quit and it'll stay with you? No. But if you keep your maintenance up, you will keep having lots of gamma waves. I don't know how you want to put it. You'll be near Satori for long periods.
I love that. I love. By the way, I think your speaker got turned up, and I can hear me.
I didn't touch
I know. It just okay. It stopped doing it. All right, that must be a Skype glitch. Okay, sorry, Jeremy, my editor. Okay, thank you so much for talking about what's required to keep the symptoms in check for a long period of time, because I think the way you phrase it is really important. Not a cure. a treatment and part of a lifestyle that requires some maintenance, but all the things that you were talking about in the maintenance are healthy parts of a healthy routine, regardless of a person, whether they have depression or another mental health issue or not. So
Yes.
yeah, sleep hygiene, all mindfulness, all of those things. Now, can you talk specifically about, you mentioned depression and then you mentioned PTSD. What are the most prevalent conditions you see in your clinic?
Okay, I'm going to give you an aside here. I hope it works. Because I was just interviewed by someone who really wants to stop the get-rich-quick people in ketamine. And it's such a ticklish needle to thread, because I want to stop those people also. But in doing that, they kind of want to fence off what the indications are. Oh, if you're using ketamine for postpartum depression, you're a cavalier and you're an adventurer and you're an outlier and we should stop you. So a study comes out, I read it Monday, 300, several hundred Chinese women getting 10 milligrams of ketamine about 10 minutes after cord clamp from delivery. Postpartum depression being the leading cause of maternal death in the first post-birth year, okay? Suicide rate is less than half.
Wow, in those 30 women?
Not 30,
or sorry,
300.
In those 300 women. Wow.
Now, do you want to call somebody an adventurer or an outlier because he took the conceptual leap of trying ketamine on postpartum depression with all the issues of milk and liability until the kid is 20 and 21 and blah, blah, blah? Okay, we don't know what all the indications are. I use ketamine for depression, for PTSD, for suicidality. It's amazing for suicidality. Some OCD, and it's hard to know which. Lots of chronic pain, especially central sensitization, what we call CRPS. It's just amazing. Okay? For trigeminal neuralgia, for some diabetic neuropathies. Okay? That's what I use it for. But I promise you, there are really useful indications that we have no concept of. And we have to stop the adventurers and the outliers and the greedy ones while not preventing further exploration of this amazing drug.
Yeah, absolutely. That's probably a very delicate balance that a lot of people are working with right now, for sure. Can you talk a little bit about, I had not yet heard that it had been used for different pain syndromes.
Oh, not the same protocol that we use for depression.
Okay.
Yes, it's phenomenal for pain. For central sensitization, if you'll divide pain into anatomic pain and central pain. Anatomic pain, you got a broken bone, the pieces are sticking out, and it hurts. Okay, ketamine is great for taking away that pain as long as you give ketamine. But you have to fix the bone or all bets are off, okay? The opposite of that kind of pain is phantom limb pain. The limb was blown off in a mine accident, and it's not there, and everybody knows it's not there. But people are not making it up or malingering. Their lower leg hurts, and their lower leg is buried in another country. Okay, for that central kind of sensitization and central windup, ketamine is amazing.
Do you know what it
Not
does,
just
how it works?
I can tell you the mechanism du jour.
Sure.
It'll be different next week. But right now we think, we know that ketamine causes proliferation of receptor sites and dendrites and connections, particularly in certain areas of the brain. We demonstrate this readily in laboratory models. Most people aren't willing to have their brains biopsied, so we don't do that with people. I'm being cute. We don't ask.
Nobody.
And you take the little mates of these laboratory subjects and redepress them, and those areas involute. And you give them more ketamine, and those areas plump up again. I mean, not them, but their litter mates. It's pretty remarkable. We used to think it was by NMDA receptors, and we thought it was by AMPA receptors. Now we think it's probably AMPA starting a whole cascade that leads to brain-derived neurotropic factor, and that as it is elaborated, it stimulates new growth in certain areas of the brain, particularly the amygdala, the lateral habenula, the prefrontal cortex, and other areas.
Wow.
So why do you need boosters? Well, these areas tend to involute if you don't have boosters, even without re-challenging with depressive experiences.
So how long?
But you do definitely get the new growth.
Gotcha. So for the pain patients, how many sessions do they usually take, and then how long does that last, the effect?
It depends a lot on the pain. Trigeminal neuralgia, you can do 2 sessions typically, and they're going to be relieved for many years.
Wow.
Fibromyalgia, 5 sessions. These are 4-hour sessions, high-dose ketamine. And they get somewhere between 3 months and a year. It depends a lot on the onset of their problem. The sooner we get them after the onset, you get a CRPS within 2 years. That's complex regional pain syndrome. That's another name for it. If you do that within a couple of years, you can get, I hate to use the word, but a cure. But you wait a decade or so, and we often end up waiting a decade because a lot of these are orthopedic injuries, and orthopedists have CRPS very low on their radar, under their radar. So it takes a long time before they say, you know, you're not malingering, and I've tried everything. I wonder if it could be CRPS. The longer you wait with CRPS, the more likely you're going to get relief, not total remission.
Yeah, that makes sense.
But people don't mind that. I mean, they mind it, but if they've been going along with a 7 or 8 or 9 pain scale and inability to be spouses, parents, employees, and you bring it down to a 3, and they say, damn, I still hurt, but I can get out and do what I like to do. I can be the person I want to be, or close, much closer. And I have to come in every 6 months for a booster, and it's okay, or 2 boosters. And it's all right because, God, what a gift.
Yeah.
So it's fun.
Absolutely. How about, now you said that treatment-resistant depression, that the effects usually last for 3 months. That's after how many sessions?
No, I said the average lasts for 3
okay.
months. We have people out 2 years.
Oh, wow.
And we've had people who need boosters after 6 weeks. Literally. But the mode seems to be around
Gotcha.
3 months.
And that's after how many sessions?
6 sessions over 2 to 3 weeks. The sessions are about an hour. The interval between sessions matters a lot, but we don't know what really the parameters are. But between session 1 and session 2, 48 to 72 hours is good. More than 72 hours, you might as well start over. That's our opinion. We don't have real data on that. It's consistent with our observations, but our denominator isn't large enough to really know. Am I getting too funky?
No, I love this. It's perfect.
Okay.
Perfect amount of funk.
Okay. Our sessions are about, our first session is 50 minutes. Our subsequent ones are 55. We end up giving around 3/4 of a milligram per kilogram over the 55 minutes. I mention this because all of the literature, like the Zarate study with its amazing results of 71%, for reasons that are somewhat obscure, they chose 0.5 milligram per kilogram over 40 minutes. And they got 71%. Replications of this have numerous times very closely gotten between 68 and 71%. We get 83%. Why? Do I have magic? Do I have a special pipeline to somebody who causes new growth in the brain? No. We give a little more ketamine than that, and our infusions are a little longer than that. And that makes all the difference. Now, I haven't mentioned anything about the setting and the mental set. We are meticulous about that in my clinic. It's Ketamine Clinics, Los Angeles. Not everyone is. It makes a huge difference. We've got about 3 groups doing ketamine right now. You've got or 4 groups. You've got senior people who've been doing this for a long time, and a number of years is a long time. And they have pretty stable technique. You have the newcomers who really want to do it right, and they're evolving quick. They accept coaching, they accept mentorship, and they get pretty good pretty fast. Then you have people who are in this, and they provide a good, safe setting, but they're not involved with mental set. They're not very interested in what happened before the patient got there, and they don't care very much what happens after the patient leaves. And I don't say they don't care. Their care isn't operational if they have care, because they don't do anything to facilitate a handoff.
Sure.
Okay? This is not a cure. This is a treatment. In isolation, it's bound to fail. Now, do you call it failing if they need a booster in 5 weeks or 6 weeks? Or do you call it an opportunity to sell another infusion? That's up to you. Because a booster or 2 boosters will usually restore people to the level of benefit they had at the end of their first series. Okay? So, you were asked how many, and I told you how many, and I told you we give it a little more and a little longer, we get a better result.
Yes.
83% is way better than 71.
Yeah, absolutely. And I'd love to hear you talk a little bit more about, so for those of you listening who are not familiar with set and setting, set is the mindset that somebody comes in with. This is a very brief description, and setting is where you are taking the medication. And so you were talking about places have, a safe setting, but they may not focus so much on the mindset. And so can you tell me what you guys do to focus on the mindset and prime it for the therapy?
Sure, but I want to break down. Safe setting has a couple components. One component is that the setting really be safe, that there be RNs who have ACLS, who know where the crash cart is, and the defibrillator battery works, and the backup power for the suction works, and the oxygen bottles are full of oxygen, and we know where the airways are. So that's safety at one level. The other for the patient is experientially safety. Do they feel chill? Is this a mellow surround? Is this a place where they can reduce their vigilance? Is this a place where they can not feel judged? Does this have a staff that listens to them like they weren't interrupting something more important? Does the staff seem compassionate? Is their issue and their problem and their concern a priority for us? That moves right into the mental set. And the mental set, although you're right, they do come with a mental set. Much can be done right at the time to facilitate the development of a constructive set. You can go to very dark places with ketamine. Ketamine is a fuel. It's a great enhancer of resilience. But initially, particularly, the first experience with it can be off-putting, can be scary. It's a dissociative anesthetic. It's not really a hallucinogen. And I say not really. People do kind of see things sometimes. But if you ask them, are those pink dresses or is that dragon really there? Or just you're seeing it, but you know it's not in fact real? They almost always acknowledge, yeah, it's not real. Dissociation is a huge spectrum. When you're standing online at the grocery store waiting to pay and you're thinking about what you're going to do tonight, you're disassociating. Toward the other end of that spectrum, you can be so altered, so intoxicated, that you don't know who you are or where you are, or which end is up. What some people call ego death, and I see people giving ketamine promising they're going to give more than the next person. You come to my clinic and I will really give you a lot of ketamine. Well, that is so bad. And in the race to get patients, stuff like that is coming out. It really sucks. It's horrible. Because if the ego isn't there, if the executive function isn't intact, it's much harder for you to make good use of the experience in a therapeutic manner. So you want a certain amount of dissociation, but you want the right amount. We have found that coarse horizontal nystagmus is a very good physical indicator of the sweet spot. And it's great to have a physical indicator. We also interview. When we start our infusions, we go in 6 to 7 minutes later and we interview the patient. And we have a dialogue about where they are. And we want them to be dissociated, but to a manageable degree. We don't want to terrify them. And we don't want to leave their executive function impaired or cause their executive function to be impaired so that they can't make good use of the doors we're opening for, helping them to open.
Yeah, that's really important. So they come in and you do all these things to help their set, and you've got this facilitative, calm setting. Is there anything you recommend they do before coming to the clinic to prepare?
No, it's a little like healing. We don't know how to make healing go faster, but we know a million ways to make it go slower, and we advise against those. You don't pick at your scabs. You don't leave your wounds dirty. If you come to the clinic late and apologetic and full of self-judgment and sure that the doctor is pissed off at you, it's going to be hard to have a good infusion. If you've agreed not to have food 4 hours before and you had a hamburger half an hour before, it's going to increase your anxiety level. Tell the doctor, because otherwise it's going to fester and get in the way. If you have a therapist, it's great to talk to your therapist. You can either think about your therapy and think about the elephant in the room that you have not been able to talk to for 15 months and say, I'm going to talk to that elephant and see about if he'd come out during therapy. Or you can even get with your therapist and say, hey, should we create an intention together so when I go see Mandel, I'm going to have something specific to work on?
I like that, the intention setting. Do you recommend that generally?
Yes.
Have you found that, like, for each of the therapy sessions there's a different intention, or is it like one intention for the treatment, like the 6-week or the 6-session course?
I go a little light on asking people to get real granular about their intentions. I want to be therapeutic. I want our relationship to be therapeutic. If they have an ongoing relationship with a therapist, I don't want to intrude on it. And I don't want to get the energy, because they told me all about it in the first 10 minutes when they're really very present to what happened. I don't want that energy poured out on me. I want it saved for their ongoing relationship.
That makes sense.
I mean, I really do want it. I love it, but it's therapeutic. It's not in the best interest of the patient. That makes sense.
And can you talk a little bit about the aftercare that you put them, or that you, I don't want to say put them through, but that you advise?
We give them an aftercare guide, and it includes the things I mentioned earlier, sleep, nutrition, exercise, talking therapy, interpersonal relationship with a peer, intimate relationship. We're finding more and more people want to be able to dialogue about this with other people who have suffered from depression. So we're going to be starting a drop-in chat therapeutic session for people who have depression and who've had benefit from ketamine to chat with one another, because they seem to get a tremendous amount of support and affirmation from doing so. And they can also dialogue about better ways to use the experience. They know more about how it feels than I do.
Yeah.
And they're quite willing to share with one another about it. Not every one of them. Some of them are still very closed off. But ketamine makes you more, not makes you, but it can help you to become more open, more resilient. Your sense of worthlessness and hopelessness and helplessness goes away. Your ability to give yourself permission to experience pleasure gets much, much better.
I appreciate that. Yeah, I
And
love
that's
that you're
it.
facilitating that conversation between patients. That's beautiful.
So that's what we do. And we also we start measuring people's mood before we treat them. And we measure during and we measure it after. And we measure it in ways that are accessible to the patient as well as us so they can see where they are. We don't give boosters by the calendar. We don't say, oh, it's 6 weeks, it's time for your booster. No. We may be 2 weeks too late or a year early. And these are expensive and they're time consuming. And it is, after all, a drug. And we don't give any more of it than we need to give to get the effect that we want. Sometimes that's a lot, but we don't want to give more than that or more often. So we both, patient and us, follow their mood monitor. And they get a daily text message. They get a PHQ-9 every 2 weeks. They do a Beck depression inventory. They do a variety of things. When their mood begins to dwindle, as it usually does after a few months, we invite them to have boosters, typically 2 boosters, because we find 2 boosters are way better than 1 booster, and ideally with a day between. And that usually restores them to the benefit they had at the end of their first series.
Which is, are there contraindications and what side effects could people expect? Not expect, but
There are
keep an eye out for.
There are no adverse long-term side effects from ketamine given therapeutically. Ketamine's a drug, okay? It's a medicine. It's got 3 major users. Anesthesiologists for analgesia and anesthesia. Partiers to get stoned. And people being therapeutic to treat mood disorders and pain. There are 3 different dosage ranges, or 4. The whole kinetics of it are different. So when I say there are no long-term adverse side effects of ketamine, I mean ketamine used therapeutically. The people putting 1.5 grams up their nose every day for years have bad problems with their bladders, sometimes their kidneys. Many people claim that they also have cognitive dysfunction, and cognitive dysfunction has been shown in laboratory models. But when you ask people for citations, show me the human who has cognitive dysfunction from ketamine, they kind of shrink away. I haven't found any. If anybody listening has a citation, I would like to have it. No kidding. But the ketamine cystitis, which is an entity histologically different from other chronic cystitis is, that's a real thing. And it's really a problem, and you don't get it. It's been reported with therapeutic ketamine, but impossible to know the incidence. It's impossible to know if it was actually from the ketamine. And I've treated lots of people who have cystitis and who need ketamine and who just, gritted their teeth and took it and didn't have an exacerbation. And there are techniques and medicines that you can use to minimize the likelihood of an exacerbation. But that could happen. But you know what? No. Ketamine in therapeutic doses for depression, for mood disorders, has no long-term adverse side effects. But you had another question.
Anybody who should not try ketamine therapy.
Just like the indications for using it keep growing, the contraindications keep shrinking. No kidding. We never give ketamine to people on Lamictal because it's just a no-no. Well, it turns out if you wait 6 hours between the two, it's just fine. I would never give ketamine to MAOI patients because, oh God, if you gave both at the same time, it would be a disaster. Well, I treat people with MAO, on MAOs, Parnate, big time, or SAMs, or other MAOIs all the time. They do just fine. It's just not true. I don't treat bipolar type 1s who are manic at the time of requesting treatment. I take care of them as best I can, but I don't give them ketamine. For the hypomanics that are amping up, that are starting to make bad decisions, that are starting not to sleep, that are starting to make lists, that maybe are beginning to spend a little too much and wake up with strangers, not good for giving ketamine, not good. Other than that, I've had a few really, really rigid paranoid schizophrenics. Tough way to go. But we're really talking about a tiny group of people here. Depression is the leading cause of disability in our country. More than heart disease, more than cancer, more than accidents.
Wow.
This relieves depression. Suicide is the 10th leading cause of death. We lose like almost 45,000 people every year from suicide. 25 times that number attempt suicide. This relieves suicidality even better than it relieves depression. It's amazing.
Wow. On that edge, would you like to share some of your, as we wrap up, I'd love to hear some of your favorite success stories.
Oh, I don't know where to start. I had a guy who had sold out his company for around $90 million and took to his bed profoundly depressed. And after about almost 2 years of trying everything, he came to me. He had not been able to be a good father to his kids. He hadn't been much of a husband. He has houses in all the right places. He's got like 5 houses. And he hadn't been to any of them. He'd been in his apartment in San Francisco, basically with his covers over his head. No BS. And he's having his life again. Literally. He's going back to his houses in his ski areas and his houses in Europe, and he's being a dad and a husband, and he's managing his own bounty. I had a guy whose sons shot themselves to death, one on the anniversary of the others, one at 14 and one at 16, and who was profoundly depressed. Now, that would seem like a situational depression, but of course it wasn't, but it certainly rekindled the profound depression he had as a youth from abuse. And he shares this widely on the web. He is so happy with what ketamine has brought him. I had a professor from Caltech who was depressed, really badly depressed, but also dying of cancer. But she said, I got a couple of years and I don't want to live and feeling like this. So I'm going to go out now, or you're going to help me to enjoy what I got better. And I did, or the medicine did, and I helped. I have just so many freshmen and sophomores in college who are confronted with feeling small and weak and alone and full of judgment, and comparing what they know of their insides to what they see of other people's outsides, and just being paralyzed by it. And they come in and they have a series and they're reborn. It's
I
wonderful to
love
see.
that. I love that. Thank you so much for sharing that with me. Could you tell everybody where they can find more information about you and your center?
They can go to ketamineclinics.com, or they can call 310-270-0625. We'd love to help you. If you're not nearby, we'll help you to find somebody nearer to you. We want to do this for you. But if you can't, if it doesn't work for you to have us do it, we want you to get it from someone else. We want you to get it if you need it. We have people coming from literally all over the world. We had people here from Australia last year. I'm sorry, last week. And you know, it's so, in a way, flattering to see people come from Australia. And it's such a crime that they can't get this amazing life-saving treatment in their own country. It's terrible. So go to ketamineclinics.com, call 310-270-0625. We'll take care of you, or we'll find you someone closer to home, if it's legal, closer to your home.
I appreciate that very much. I love the fact that if it's not you, you still help find them a quality therapeutic treatment center. Thank you so much for joining me today.
I'm really glad, Anne-Marie. I hope it came out well. I really enjoyed doing it.
Perfect. Until next time, everyone.